Hello everyone and welcome to The Explainer. I am so incredibly excited to jump right into today's topic with you. We're looking at a truly fascinating piece of medical science, intravenous induction agents. Honestly, it's best to think of these as the anesthetist's highly specialized toolkit. Because putting a patient to sleep safely, well, it isn't just about pushing a button. It's about selecting the exact right chemical tool for the specific, unique human being sitting right in front of you. So let's explore how these powerful drugs actually work.
To start us off, what are we actually searching for here? Let's compare the ideal agent with our everyday medical reality. In a perfect world, we'd have a magic potion, right? A drug that's dirt cheap, completely stable on the shelf, totally pain-free when injected, and works almost instantly with a hangover-free recovery. We'd want it to keep the heart and lungs perfectly stable, cause absolutely zero nausea, and be entirely safe for folks with rare conditions like porphyria. But, well, here's the reality check. No single drug exists that checks every single one of those boxes. And that's exactly why anesthesiologists need such a diverse toolkit.
So here is our roadmap for today. First, the anesthesia toolkit. Second, thiopentone, the brain protector. Third, propofol, the day trip sedative. Fourth, etomidate, the cardiac shield. Fifth, ketamine, the trauma lifeguard. And finally, choosing your agent safely.
Section 1. The Anesthesia Toolkit.
Okay, let's dive into this. Before we start pulling individual drugs out of the bag, we kind of need to understand the basic ground rules. How do these medications actually switch the brain off? While the ultra-specific mechanics for every single drug aren't perfectly mapped out, it generally boils down to two major pathways. First, you've got the stimulation of GABA A receptors. Think of GABA as the brain's brake pedal. These drugs press that brake hard, essentially telling neuronal activity to slow way down. Second, we have the inhibition of NMDA receptors, which are found on the excitatory glutaminergic neurons. NMDA is basically the brain's gas pedal. So, by slamming on the brake and completely lifting off the gas, we dramatically drop neuronal activity, and boom, you get a state of anesthesia.
Now, what actually happens once the drug hits the bloodstream? This is such a crucial concept. Following an IV injection, you get this huge, rapid spike in plasma concentration. The drug then quickly diffuses across the blood-brain barrier to do its job. But step 4 is where the real magic happens, redistribution. You see, a patient initially wakes up from an induction agent not because their liver has somehow rapidly chewed up all the drug. No, they wake up because the drug redistributes away from the brain and outward into slower tissues like fat and muscle. The concentration in the brain drops and the patient opens their eyes.
Section 2. Thiopentone, the brain protector.
Meet thiopentone. It's a barbiturate, and it actually starts out as this yellowish powder that gets mixed into a highly alkaline solution. Fun fact, that solution is bacteriostatic, meaning it stops bacteria from growing, so it can safely sit on the counter for 24 to 48 hours once it's mixed. Now picture this clinical scenario. A patient is rolled into the emergency room, and they are actively seizing. Their brain is just in massive overdrive, their intracranial pressure is likely skyrocketing, and they need to be intubated and put to sleep right this second. Which tool are you going to reach for? You reach for thiopentone.
And here's exactly why. Given at a dose of 4 to 5 milligrams per kilogram, thiopentone is incredibly fast. The onset is less than 30 seconds. In the central nervous system, it acts as a very potent anticonvulsant. It actively shuts down the seizure while simultaneously dropping cerebral blood flow and intracranial pressure. It's literally the ultimate brain protector. But, cardiovascularly speaking, it decreases myocardial contractility, cardiac output, and blood pressure. So you fix the brain, but you absolutely have to be ready to support the heart.
But here's the catch, and it's a big one. Thiopentone has some severe flaws. Remember how I mentioned it's a highly alkaline solution? Well, if your IV needle slips and you accidentally inject it into the surrounding tissue instead of the vein, it can cause severe tissue necrosis. We're talking actual cell death. It can also trigger a histamine release, leading to life-threatening bronchospasm that completely clamps down the airways. So it's a really tricky choice for someone with severe asthma. And crucially, it can precipitate acute, very dangerous attacks of a rare metabolic disorder called porphyria.
Section 3. Propofol, the day trip sedative.
Let's move on to our second tool, which is arguably the most famous induction agent out there, propofol. It's a phenol derivative, and you've probably seen it. It's that distinct, whitish, milky emulsion containing soy oil, egg phosphatidates, and glycerol. Okay, so imagine this scenario. You've got a healthy 30-year-old coming in for a quick, routine 20-minute day surgery. They want to go to sleep, wake up fast, head home, and they are absolutely dreading the idea of waking up nauseous. For this job, propofol is your absolute best friend.
You dose it right around 2 to 2.5 milligrams per kilogram, and it works fast, about 20 to 40 seconds. But its real superpower? The wake-up. Patients wake up in about 5 minutes with a beautifully clear head and practically zero hangover. Even better, it has natural antiemetic properties, meaning it actually fights off nausea and vomiting. Because the recovery is just so incredibly smooth, it's the gold standard for total intravenous anesthesia, or TIVA. One quick note though, it has zero antimicrobial properties. It's basically a buffet for bacteria. So once you draw it up, whatever you don't use has to be thrown away immediately.
But, of course, propofol isn't flawless. Medical literature gives us a very stark warning about it. It causes the most marked fall in blood pressure among all the induction agents. It literally bottoms out the blood pressure, which is why you have to push it slowly. It also causes profound respiratory depression, and honestly, it really hurts going into the vein. Oh, and because it quickly crosses the placenta, and we don't fully know the safety profile for newborns, manufacturers don't recommend using it for neonates, lactating mothers, or during pregnancy.
Section 4. Etomidate, the cardiac shield.
Next up, meet etomidate. This is a carboxylated imidazole ester. Just like propofol, it stings on injection and it regularly causes thrombophlebitis, which is basically vein inflammation. So if possible, you really want to put this into a nice, large, flowing vein. Now let's look at a really high-stakes scenario. You've got an 80-year-old patient who urgently needs surgery, but they have severe heart failure. Their cardiovascular system is just barely hanging on. If you give them propofol or thiopentone, that massive drop in blood pressure we just talked about, it could literally kill them. You need a shield for their heart.
And etomidate's cardiovascular profile is precisely why it exists in the toolkit. Dosed at 0.3 milligrams per kilogram, etomidate is hands down the most cardiostable agent we've got. It quietly puts the brain to sleep while leaving the heart rate and the blood pressure virtually completely untouched. It also causes quite a bit less respiratory depression than propofol, though it can cause some slightly weird physical side effects, like spontaneous coughing or hiccups as the patient is going under.
But you knew there had to be a massive trade-off, right? Etomidate's fatal flaw is adrenal suppression. It actively blocks an enzyme called 11B hydroxylase. Why does that matter? Well, that enzyme is absolutely critical for your adrenal glands to pump out steroids. And your body desperately needs those steroids to fight the massive stress of surgery and illness. Because it essentially unplugs your body's natural stress response system, its use in the real world is incredibly limited, mostly reserved for single-dose, extreme emergency inductions in very fragile patients.
Section 5. Ketamine, the trauma lifeguard.
Let's bring out our final major tool, ketamine. This is a phencyclidine derivative. And unlike the others we've discussed, it's incredibly versatile. You can give it IV, intramuscularly, you name it. Now, consider this absolute nightmare of a scenario. A patient arrives by ambulance after a major chaotic trauma. They've lost a ton of blood, they are severely hypovolemic, their blood pressure is totally crashing, and they are in absolute agony. If you give them propofol, their blood pressure hits the floor and they code. You need a drug that does the exact opposite of everything we've looked at so far.
You need ketamine. Given at an IV dose of 1.5 to 2 milligrams per kilogram, ketamine is totally unique. Instead of depressing everything, it actively stimulates the sympathetic nervous system. It actually increases blood pressure, heart rate, and cardiac output. That makes it an absolute, literal lifesaver for hypovolemic, crashing patients. It's also a bronchodilator, which pops the airways wide open. And crucially, it is the only induction agent on our list today that actually provides potent analgesia. It actively fights pain while putting you to sleep.
Now, what's really fascinating here is the psychological cost of all those physical benefits. Ketamine creates what we call dissociative anesthesia. The patient is entirely disconnected from their environment. And as they wake up, they can experience what's known as emergence phenomena, which are essentially really intense hallucinations or nightmares, along with a pretty heavy, prolonged hangover and amnesia. Medically speaking, it also increases cerebral blood flow and intracranial pressure, which means despite being amazing for a lot of traumas, you generally have to avoid it in severe head injuries.
Section 6. Choosing your agent safely.
Okay, we've opened the toolkit, dug into the molecular mechanisms, and looked closely at 4 incredibly different agents. Let's synthesize all this clinical knowledge into one ultimate cheat sheet. If you're dealing with a patient having actively uncontrolled seizures or someone who desperately needs neuroprotection, thiopentone is your brain protector. If you have a totally healthy patient just wanting a smooth, nausea-free day surgery, propofol is your day trip sedative. If your patient has severe heart failure and absolutely cannot tolerate a blood pressure drop, etomidate is your cardiac shield. And if you are staring down a massive trauma with hypovolemic shock, ketamine is your trauma lifeguard.
As we've seen, every single one of these drugs is an extreme balancing act. Waking up flawlessly with propofol, it costs your blood pressure.
Protecting a failing heart with etomidate, it shuts down your adrenal glands. Saving a bleeding trauma patient with ketamine, it costs you psychological smoothness. So, knowing all these dramatic, completely life-altering trade-offs, how will pharmacology ever engineer that truly perfect magic potion of an induction agent we dreamed about at the very beginning? It is a fascinating puzzle, and it's exactly what drives anesthetic research forward every single day. Thank you so much for joining me on this explainer. I really hope you found this as genuinely fascinating as I do, and I highly encourage you to keep exploring the incredible, high-stakes world of medical science.